And the expert on the stage said, why are you trying to get me to say that you can do something that you're not legally allowed to do? You're never going to get me to buy in. If you want to be the guy hiding something in the closet, why are you out here looking for legitimacy? The legitimacy is going to come when you do the things that are improved. So I think that's a weird dynamic that's happening here because it's so cutting edge, right?
Hey, welcome back to the Aesthetic Appeal Podcast, the official podcast for aesthetic brokers. We're here live all day today at the Aesthetic Show at the gorgeous Wynn Resort. And with me in this episode, Tom Terranova of Quad A. Tom, welcome to the show.
Thank you. Thanks for having me here in this, as you said, beautiful venue.
It's pretty impressive, right?
Yeah.
So, Tom, Quad A.
Yes.
What is Quad A?
So Quad A is a 47-year-old nonprofit organization, nonprofit business, tax-exempt business, however you want to term it, that is dedicated to patient safety. And so a lot of people are dedicated to patient safety, but the way that we operationalize that mission is to conduct on-site assessments of medical facilities for quality and safety. So the whole purpose of the organization is to be a self-improvement mechanism for the medical industry and to be a beacon and a standard bearer for quality and safety and confidence building and trust building for patients and for the public and regulators. So that's the very, very generic version. I can go into it deeper if you want, but that's sort of the flyby version.
Now, I can tell by your thick Texas accent that, no, where are you from, Tom? And give us a little background on you.
Yeah, so I'm born and raised in Chicago. Interesting that you said a thick Texas accent. I think I spent every summer of my life from age about 8 to 16 in Texas. I don't think I got the accent, but I did get some weird terminology. So if you hear a guy with a Chicago accent saying y'all a lot, it's probably me. So that's I opted for y'all instead of use guys, which is the Chicago version of y'all.
Chicago use guys.
So yeah, that's me. Background wise, I've been with Quad A since 2009 in various capacities.
Wait, I want you to don't skip over this part. Tell us about your academic background and why that all came about. And I think it's very important of how that led into you leading the organization.
Sure. Yeah, you're pulling the curtain back on our conversations, which I love. So I mean, let's go back in the Wayback Machine. So I actually started school at Tulane University in New Orleans. Hated it there. I love the school, love New Orleans. Didn't like the
I'm sure you love Fat Tuesday.
Exactly. Yeah. I was not a cultural fit at the school. I'll just put it that way. So I went to Loyola University in Chicago. I was actually a dual major in political science, international relations. Went to grad school at the University of Chicago in an interdisciplinary committee called Committee on Foreign Relations. Did about a third of my coursework in law, about a third of my coursework in public policy, and about a third in the School of Social Sciences and Business, kind of split.
And how does that at all tie into the plastic surgery and medical aesthetic universe?
It doesn't until you start working, and then you get into really interesting stuff. So about 2007, I went to work for a person who is at the time was the head of Northwestern's. I'm going to get this wrong, but I think it's like the Ford Center for Organizational Psychology, Philosophy, something like that. But essentially it was in the business school at Northwestern at Kellogg. And it's essentially about how organizations behave. And it was fascinating consultancy that he had. I mean, we're surrounded by AI organizations and people selling bots and things like that. And the reality is, like, back in 2006, we were working in the infancy of that. And these brilliant mathematicians at HEC in Montreal had developed algorithms that scraped the internet, like 6 billion pieces of news a day.
6 billion.
I think those are the B. I'm going back 25 years here now. So correct me, don't hold me on it, but it was a tremendous amount, 4 to 6 billion pieces of news items a day. When I say news items, it might be consumer blogs or like message boards back in the day. And so they were doing that in 35 languages and then providing the data to us as human intelligence. And then we had to anticipate what was happening for our clients. And this was stuff that wouldn't typically show up on the stock market. So it would be things like, hey, there's a protest movement going on in an area that's critical to your supply chain. about deforestation or whatever it may be, and it's going to affect your supply chain, and you're going to have delays, or you're going to have adulterated product or whatever. And so we did what was called predictive analytics now, and what's pretty cool and easily automated back then. And so it was really fascinating. And long story long, we wound up doing a project for an international, a multinational insurer that was starting to explore covering patients going abroad for care.
Here we go.
You could go into India, for example, and get a really complex heart procedure for a fifth of the cost of the US. And so insurers at the time would say, okay, well, we're going to pay first class airfare for you and a companion. We're going to pay for your 5-star luxury hotel. We're going to pay for your heart surgery or joint replacement or whatever it may be. And then for convalescent time, and actually give you some pocket money to spend, because it's still going to wind up being 30 or 40% of what we pay for a quadruple bypass in the US.
And you're looking at efficacy and what's the risk profile.
Correct.
And so now we're into risk.
Yeah. And so we did a huge project for some of those folks. And then the Great Recession hit. And while this was all incredibly fascinating and really interesting stuff that we were doing, it's a little harder for a board of a major Fortune 500 company when the stocks are going down, discretionary spending is getting cut, to spend on something so esoteric as this. And so the place shuttered, and I was 6 months from my wedding without a job and looking for a job. And at the time, Quad A, which was then known by its more formal name, the American Association for Accreditation of Ambulatory Surgery Facilities, and you could see why we didn't answer the phone that way. They were looking for somebody to work in legislative affairs, which was essentially my background at this point, and had a point in their job posting about medical travel, about our international program, which had started in 2005. And so the point there was patients going abroad for what they called medical tourism. I hate that term. I call it health travel, medical travel, because it's not tourism. If anybody out there is thinking about healthcare tourism, you're not getting a quadruple bypass and then hanging out on the beach in Bali.
Right.
You're not getting a breast augmentation and then going to sun yourself in Rio. You're going to be bruised and messed up. So it's not medical tourism. In fact, if you go to some of these really wonderful hospitals, the hospitals are great, but the infrastructure around them might prevent you doing anything really.
Right.
One of the stories I heard was about knee replacement in India, and they said the hospital's great, airport's great, but when you're going from the hospital to the airport and you spend 6 hours with your new knee bent in the back of a tuk-tuk on bumpy roads, it's probably not the best for the knee replacement. So again, separate from that tangent, that's really what drew me to Quad A. I came into the organization in 2009, really as the person who was going to be the point of contact for all legislative affairs regarding safety legislation, safety regulation in any of the states by the federal government. And then as diverse foreign governments wanted to kind of regulate the space around whether it was medical travel, plastics and aesthetic surgery, in some cases like kind of cosmetic dentistry, but kind of anything where the patient was going to be involved, where the government wanted to speak or have a position on it, that would be my role. And we were, we don't lobby. We're not allowed to lobby. We don't advocate at all. So we just do technical advisory role. So anytime that came up, we would say, okay, here's how it's going to affect access. Here's how you can effectively get oversight. Here's how we can get, healthcare at the table as opposed to some regulator. Most people don't, I think if they stop to think about it, they'd realize most regulation and legislation is either written by sort of an advocacy group or maybe, some congressional aide who's probably like, in their 20s.
One of 9 things that they're focused on as an expert.
Exactly. So, for us, one of the big things is to have medicine at the table, have them writing the standards, have it be clinically relevant, have it be clinically important, and then kind of turn it over as an easy off-ramp to the government to say, what you guys are focused on, safety is great, but the mechanisms you're pulling may not be the most effective way to get there. Here's a program that allows you to do that. If you want, we can partner with you to provide oversight.
I love risk assessment and safety as it ties into the aesthetic and wellness space because
you're one of 3 people who love risk assessment and safety. Go ahead.
Well,
maybe 4 people.
I think it goes back to conversations that you and I have had in the past, right? And having grown up in my early professional career as a Marine Corps aviator, like aviation is all about Lean Six Sigma and how do we minimize risk, right? If we can make it replicable time after time after time and get the sets and reps that need to be involved to build a curriculum that is repeatable at a very commonplace level. In aesthetics, it ends up being lower mortality, higher efficacy, better patient outcomes, And I think that is what is going to drive the industry even more wildly successful than it already has over the last 30 years.
Right. Yeah, you're 100% right. And that has, I mean, Quad A's origin stories in plastic surgery for that very reason. It was sort of what was going to drive safety that allowed the industry to progress. And we started in 1980 in that space, in the surgical aesthetic space, because of the variability, right, and the lack of repeatability and the lack of sort of predictability, right? Like, I'm a lawyer.
Give me one example. So he is a lawyer by trade. So everything that we're saying is in the presence of my attorney. I just want that to be clear.
Yeah, I should probably give the general disclaimer too, right? Nothing I'm giving is legal advice. Don't take this as legal advice. Consult your own attorney. I also went to business school. I'm not going to give you business advice either.
But give me one example. I want to use this to parlay into another question.
Yeah.
Give me one example in the plastic surgery space where, surgeons are highly competitive, highly competent, extremely confident, especially plastic surgeons are extremely confident individuals. Do not walk into their space and tell them that they're messed up.
Yeah.
You better prove it.
Yeah.
Show me one example that Quad A helped in that space.
There's numerous examples. The best one is we've been in this longitudinal series of reports and papers written by academics, going back to, I want to say the first one was like 2004. And so the physician who created our data reporting system was really a visionary. He was way ahead of his time in terms of data-driven outcomes and data-driven medicine, and instituted our mandatory peer review. We used to call peer review, and now we call it patient safety data reporting in 2001. So what that is every single operating physician, every single practitioner in a Quad A accredited facility submits data, aggregate de-identified data every 3 months. It used to be 6 months, now it's 3 months. And then we pull from that rates of adverse events. So the first study was essentially establishing that the rate of complications, including death, was as low or lower in accredited facilities as they are in hospitals and published kind of federal data and licensed ASCs. Second one was 2-3 years later was when there are deaths, the leading cause of death is DVT or VTE, venous thromboembolism, pulmonary embolism, kind of the same
Say that one
family.
more time. It sounded really fast.
Deep vein thrombosis, DVT, or VTE, which is venous thromboembolism, or PE, which is pulmonary embolism.
Thank you.
Kind of the same family of complications. And those would be the leading cause of death, even when death still did happen in an accredited center. So then fast forward a few more years, and we put in place screening protocols as part of our standard. So when you're going to treat a patient, we want you as a physician, we want you as a center to go through a screening protocol with the patient and make a logical, informed decision as to how you're going to protect against VTE, DVT, that same family, based on your medical judgment. We're not telling you what you have to do. We're just saying there's a few things we tell you have to do. If you have to have sequential compression devices to keep the blood flowing, or compression socks, depending on the types of procedures. But other than that, as a physician, you may choose to medicate with blood thinners and things like that. There's other ways that you might protect a patient against these complications. And so we put in this standard saying, you have to go through this process and make an informed decision. And so that was sort of a watershed moment, because we said, this data is showing us it's a risk. Let's do something about the risk. And then a few years later, we measured the risk. And it started with a retrospective study that said, all right, let's find complications where they occurred. And then the researchers went back and looked into the medical record and found, okay, when these deaths happen, the screening wasn't proper. It was done improperly or wasn't done at all. So then fast forward a few more years, and we have a data use agreement with researchers at Harvard. And there's been a couple other intermittent studies that we've done in between. But we kind of hit what I thought was just the most fascinating study. And what they did was they finally tied compliance data, our compliance data with our standards, to those adverse events. And it was a 4-year period, a 4-year period that they looked at all the studies across over 1,000 plastic surgery facilities, 3,000 facilities that we accredit. And what they found was on any given year, when our citations, meaning the facilities weren't doing it, our citations for this screening practices went up, mortality and adverse events went up. And on years when we found the facilities overwhelmingly compliant and those citations went down, there was a dramatic drop in adverse events and mortality from DVT. And so We talked about causality and correlation.
Yes, causality versus correlation.
Yeah, we can't establish causality because that data is de-identified. So we don't know that this facility was cited and then that facility also had a DVT. So all we can do is tie occurrence. But we can see an incredibly strong correlation between citations, spiking and adverse events spiking. Citations plummeting, adverse events plummeting from 2019 to like mid 2022. And it was I'll share this with you just because it's funny as someone who loves risk assessment, as you said. The researcher for Harvard, I've never seen anybody so giddy over data before. He was sort of like... I'm
going back to Cambridge right now. I'm like, okay, I got it.
Nerdily laughing about how the confidence level and how high the interval was for the standard deviations of this to say that there's such a strong correlation between this. And he said, I've never seen such overwhelmingly clean data and such an overwhelmingly tight correlation when we can't do causality. So, from a data nerd perspective, it was pretty strong.
That's fantastic. I think the key there is it's so empowering. I think it's an empowering moment because whether you're a plastic surgeon or a med spa owner or a longevity clinic owner, it's that idea that like, I can take this data that's been anonymized. I can take it at face value and not have a blame assigned and just say, I want to make myself better.
Right.
I want to make my clinic better. I want to make my providers better and take that same mentality in everyday facets of leadership.
Right.
And it's just that extreme commitment to leadership.
Yeah. Extreme commitment to leadership. Extreme accountability, right?
Extreme accountability.
Extreme accountability. I think we were just talking about a speaker that I heard that also comes from military aviation. I think his terminology was radical accountability.
Radical accountability. I'll buy in on that.
So I am 100% at fault. I take 100% accountability for everything that goes wrong on my team, right? And that's the idea. So you don't get to say, I'm accountable for this, I take ownership of it, but you really drop the ball, right? Like we each say we're 100% to blame, right?
And I think the glove to that hand is there's got to be grace.
Yeah.
If you can extend grace to someone for taking supreme accountability, then it allows everybody to level set and believe that there's a trust that gets built quickly again to be able to pursue like-minded goals without intrepidation or caution.
Yeah, I think the point is accountability is a bad word. It's a four-letter word now because it means you're going to get fired, right?
Right.
But the reality is accountability is, okay, what were our objectives today? Here's how the behavior went. What would you do differently? What should you do differently? Do you have any doubt in your mind that you could do it the right way tomorrow? And by the way, I don't have any doubt you could do it the right way tomorrow. Yeah. And we talked about debriefing earlier, and essentially that's what it is.
A ready room debrief is horrible.
Yeah.
And it's like stand up, drop down to your most exposed self, and just get brutally, honestly told every flaw.
Extreme vulnerability, but also in that vulnerability to say, here's where I could have done something different. Here's where I should have done something different. Here's where I will do something different. And when we go do it tomorrow, it will be done this way.
Yeah.
And the grace that you say, I believe you, I believe in you, and tomorrow I want to be next to you when you do it the right way, just the way I was today when I was next to you and you didn't do it the right way. And I think that's the key. And as you said, we're sort of a watershed moment for like the med spa space. It's the same in surgery, to say we as a unit want that consistency. And when you talked about plastic surgeons, how do you sell that to them as an idea? And I think it's the same with med spa owners. I don't think anybody who's entrepreneurial and type A is any different. The point is, what you expect as an owner, as an operator, as a director is not what you're going to get. As you said, you're going to inspect what you expect. And it's not me, right? It's you as an owner. Because if I'm the surgeon, probably the person I'm paying the least attention to in my center is the person who's working the sterile supply closet.
Right.
Guess what? That person's probably as responsible or more than I am as the surgeon for whether or not I'm going to get an infection or whether I'm going to get a necrotizing fasciitis, right? Like that person is sterilizing my equipment, is storing my equipment, is potentially overloading drawers and the sterile packs are getting torn apart and ripped, or steam is leaking up into the sterile packs and violating them and contaminating them. That person is operating the way they see fit if you don't have a framework, if you don't have a structure.
When I talk about aviation safety in my previous life, I would sometimes refer to 5 love languages.
Yeah.
Because you've got to think in an average squadron, there's no less than 5 languages you're going to speak at different levels of management and leadership, and also at different areas of expertise, that you have to speak their love language and translate your vision as that med spa owner or as that plastic surgeon in owning the overall success and failure of the organization.
Yes.
It comes down to like, how can I communicate our goals and our vision and our values in a language that everybody from the medical assistant to the nurse practitioner to the esthetician to the front desk to the controller to the director of operations, how can I translate that into their language, the head of marketing?
Right.
And so
and that's the degree of formality that's required. And so to get that consistency we all, bureaucracy and formality, it's kind of, again, another 4-letter word for most of us, because it's like, I don't want to write policy. I don't want to write process. But that sort of stuff that's pushed a little bit by accreditation is not about us pushing onto a facility what our expectation is. It's about facilitating that leadership to say, I have to put down what I think is our habit on paper, so that when MedTech A calls in sick tomorrow and MedTech B steps in, it's going to happen the same way, no matter what. When I go on vacation, then my facility is going to operate, because as a business owner, if I don't have structure, I'm terrified when I leave the office, right? But as an owner, as a leader in an organization, I have this structure that I lay out in one of my executive groups. I laid it out. And it's actually the one thing that resonated the most with other leaders is we have a graduating scale of how long it should take me to be missing before you miss me, right? So if the receptionist calls in sick, it should be the worst day of everybody's life, because the phone should be ringing, mail shouldn't be getting delivered, emails are getting piled up. If you go 2 levels up, right, they should be able to be missing for a day or 2 before you notice it. By the time you get to the leader, not from a provider standpoint, because obviously you're at point of care, but from a leadership of the organization, you should be able to be gone for a month or 2 before anybody notices, before the business drops off, because you should be planning that far ahead. You should be working. I should be working in August right now. So the structure and the frameworks and the scaffolding is what allows me to have the predictability to do that.
Let's take this back to the med spa owner who doesn't understand necessarily quite yet what a Quad A certification looks like. What does it look and feel like to go through Quad A accreditation? What does it mean? What is the value in being Quad A certified? Yeah. So a couple things there. So I guess we should be explicit. So Quad A, again, has been around for 40 years, working in surgery, working in oral surgery, pediatric dentistry, other provider types. The med spa program in and of itself, we just launched in March of 2026, is pretty much a 2-year process from the very first meeting we had to start the working group to establish standards to them going live on March 12th or 13th of this year. Essentially, that came from a recognized need in the marketplace, right? The marketplace is incredibly varied. You have great providers, you have questionable providers, you have unethical providers with very little to understand who's who, right? In surgery, you have the benefit of surgeon. The term surgeon carries a lot of weight. That word does a lot of work. That means, okay, I know about residencies, fellowships. Because their curriculum has been pretty
rigorously set.
galvanized.
Yes, exactly.
Rigorous and galvanized over years and years and years.
Right. So from a med spa perspective, have you been training under somebody for 18 months? Have you done tons of theoretical and academic work? And then, have you had someone shadow you, or did you take a weekend course?
Are you certified to handle an occlusion?
Right. All of these things are incredibly varied, right, in this space. So variability, I think, is the enemy of the good practitioner, right? Because business school, right? We can differentiate 2 ways, right? We can differentiate, or we can be the lowest cost provider. Yeah. If we can't differentiate, if the market's noisy, if I can't, as I tell surgeons sometimes, and even surgeons, but more so in med spa, when you talk to a patient, you are a grain of rice. You are indistinguishable from every other grain of rice, unless we have something to distinguish you, right? And in the absence of that, it becomes price. So now we have a race to the bottom to be the most efficient, the pushiest in terms of sale, in terms of services, the lowest, I think I said lowest price, and you're trying to squeeze more and more blood from the stone. And so the very first thing is, how do we stop this race, and how do we stop all this noise and allow the good practitioners to stand out? And so that process took about 2 years. Most importantly, I want to make this very clear for the med spa community. this was not just surgeons sitting around. It started with a group of, the working group included 4 plastic surgeons who very quickly realized that they don't know what they don't know in the med spa space. And they started including dermatology, ophthalmology, OBGYN, urology, nurse practitioners, PAs, and industry. Then we used a secondary group. Not a single person in that group was physicians, to counterbalance what they said and kind of give independent feedback. And then our committee started to work through the standards. So the standards came from a place of trying to create, what does a good med spa look like?
So what does a good med spa look like? Take me through that.
So a good med spa, I'll give you 2 massive innovations in the program that I'm proud of. One is a risk stratification. So in the surgery world, almost everybody is familiar with kind of a 3-ish levels of anesthesia, whether they call it A, B, and C, or 1, 2, and 3. We're talking about, kind of topical and local anesthetic, maybe mild sedation to deeper sedation to general anesthesia. Really nothing like that exists in the med spa space, to my knowledge and to our committee's knowledge. So what they did was they set out, here are the types of services being provided in the aesthetics and wellness space. And here's how risky they tend to be, whether it's from the energy devices or the types of adverse events that could happen or the amount of training you need. And what that allows is that the accreditation standards and the expectations of the facility can grow along with the complexity and the risk profile of the services being provided. So that, again, in the surgical context, we're not looking for your anesthesia machine if you're only using local anesthetics, right? If you're using topical creams and local anesthetics, you're not delivering gases. You don't need the same kind of rescue drugs. We want to have that same proportionate rigor in med spa. So that was the first thing, right? So the first thing is, a good med spa knows what services they're providing because they need to know what kind of risk profile they are. I think that's a new innovation that the program provides. So if anybody out there is listening and they're not even thinking about getting accredited, I would suggest download the standards. They're free, they're transparent. If you can fog a mirror, you can get our standards. Download them and look at the risk stratification. If nothing else, you'll be informed as to what somebody else with scientific knowledge thinks, how risky on a scale of essentially 1 to 3, it's green, yellow, orange, how risky those procedures are and what kind of precautions you need to have in place. So I think that's number 1. Number 2 is involved leadership. And I say that because, especially in the med spa community, we all hear horror stories of the medical director 6 states away, who's the medical director of 155 med spas, has never set foot in any of them, doesn't know what's going on. They couldn't pick him out of a police lineup. And there's a bad event. Patients are in trouble. Now all of a sudden it's a medical board issue. It's a legal issue. It's prosecution. So it's about involved leadership. So the medical director needs to be actively involved in the facility. It doesn't mean they have to be there every day. Doesn't mean they have to be there 24/7. It means they have to be helping set up protocols, helping set up policy, helping review performance, helping review expectations. Most importantly, they have to understand the services being provided. They have to be somewhat familiar. They have to have a familiarity with the equipment and devices being used, the likely adverse outcomes, and how to treat them. Because whether you're a nurse practitioner, a PA, emergency room doc, or plastic surgeon, if you're not familiar with the services being provided there, how can your mid-level and your extender who's elevating the care get back up to treat it if there's an occlusion?
Tom, tell me about this. I want to talk about breaching the gap across multiple states, because you're a national organization. So how did you guys tackle and wrestle with this issue of state by state regulatory levels of constraint and restraint?
Yeah. Like every answer to every question, it's nuanced and complex, but the simple answer is, as of now, no state regulates the setting. No state regulates the environment, right? So let's take a quick detour into surgery land. There's medical boards, right? The medical board defines the practice of medicine. They give the license. They take license actions. Still in the US, barely half the states have a rule around what happens in an office surgery setting, right? So if you're in New York State, New York says any office surgery has to be accredited. If you're in sort of a lot of the kind of middle of the country, a lot of those states that are not super into regulation, you can do whatever you want in the office, right? Your medical license might be on the hook, but in terms of the setting, the process, the operation, and the organization of the setting, they're sort of silent. Where states that are active, California, New York, Florida, Washington, where they're active is to say, in the office, here's what we want an office to look like operationally. That's the world we live in. So when it gets down into the practice law, the board still has oversight over that.
Got it.
But we're looking at a surface level. Okay, you have your license, which means the board's happy with you. You have your local fire occupancy, which means we don't need to know the local fire code. So those things are surface level, and we're looking at those by extension of those formal approvals from those bodies operating in their jurisdiction. We're operating in the facility and operational level. And so that's where we're coming into the med spa space. And it's kind of virgin territory because no state has regulated that space yet. Right now, they're focused on who can hold the needle, who can hold the energy device.
Yes.
And that's their prerogative. That's not ours, right? I will say in this space, because the word injector doesn't carry the same implicit structure as surgeon does, our committee did get a little bit prescriptive with what they expect in terms of on-site training, on-the-job training, in terms of observing a certain number of cases, depending on the kind of thing you're doing, performing a certain number of cases while proctored, and then being able to operate independently, because there's no sort of universal accepted structure like there is to become a surgeon, to become board certified. So they kind of had to inject a little bit of that. So that's sort of the cop-out answer is we look to see that you have the appropriate license from the state from the practice. But then we're going to look at how the place works.
That frames it up, I think, really nicely.
It's a handoff.
I think it frames it up really nicely for med spa owners to understand. If I'm a med spa owner and I say, okay, I see the value in differentiating myself from the bottom 10 or 15%, the middle third, the upper third, and I want to be in that upper quartile of excellence where everybody recognizes in the near future a Quad A type of certification, and patients are going to educate themselves before they go to clinics. More and more and more, we're seeing that trend. So, okay, I'm buying in this thought. Tom, thank you. Now, what's my process as a med spa owner? How long does it typically take? How much time does it take me? Because I'm also running a med spa at the same time.
Yeah. So the early adopters are going to find the shortest gaps to have to bridge, because they're probably the type A people anyway. And so they probably have
They're making their own checklists.
Yeah.
And now they're like, your checklist is a little bit better than mine.
Yeah, exactly.
Thank you.
Exactly. So, I can tell you the very first clinic that got accredited, she was part of our pilot group. And when we did our pilot group, we looked for 5 volunteer facilities in 5 states. And she happens to be in Seattle, Washington. She had 10 days notice. And we basically told her, we don't want you to prepare. We want to see the state of the industry before we come in, because we want to see how far they need to come. She had 10 days notice. I think she had 2 or 3 deficiencies. When we launched the program officially, she was darn sure she was going to be the first one through. She applied within 90 minutes of the program going live. And she had a clean survey, 0 deficiencies. Now, I don't think everybody's going to do that, because especially this is a new concept in this marketplace.
Sure.
I think there's going to be gap filling to do, a lot of documentation. She said it was tens of hours in terms of writing up protocols that they had communicated verbally that were her expectation but weren't formalized. And so to that respect, I think she thought it was very valuable, that formalization.
30, 40, 50 hours.
Yeah, I think for the middle of the bell curve, it's probably a little more than that.
Yeah.
And it's all going to depend on your staffing. What we found historically is about half of our facilities can manage it with their internal staffing. Again, this goes across all of our programs. Half hire outside consultants to get it done.
Yes.
So, you could leverage that, right? You can get an outside consultant. If you're part of a national group, if you're investing and you're consolidating, obviously you have resources to handle that centrally. And the process looks like this. As I said, our program is completely transparent. Fees are on the website. Standards are on the website. You don't even wind up on a spam list if you download them. You don't even have to put in your email. Maybe my marketing team will make me change that soon. But at this point, you just download it. It's an open book test. I say you pick your toughest staff member. You make them act like they've never seen the place before, and you make them do a mock survey, and you identify your gaps. Typically, about 70% of our facilities, historically across all programs, go from a full application, a complete application, meaning they didn't send us licenses that were 10 years out of date, but a full application to conferral of accreditation in under 5 months. And there's a 30-day remediation process in there for any citations we do find. Everything's correctable. Mm-hmm. We'll work with you. That's the benefit of this, is you have a partner who says, okay, here's your problems.
It just makes you better.
It's not go to the back of the line and figure out what you did wrong for yourself and rub your nose in it. It's like, hey, here's some tools. You may consider this. So that 30-day period happens after your survey. So if you build backwards, you're talking about an application, which is all done online now. It's all on our portal. You submit that application with some credentials and some licenses from your practitioners. It's about 3 months of Q&A. It's really up to the facility. They have a year to go through the process. Some people, they do everything before they apply. So that timeline looks really short because they apply and they're like, let's go.
Yeah.
But on average, they take about 3 months. They go back and forth with our people looking for resources, asking questions. Then they give us the green light. We try to book our surveys about a month in advance so that we're not buying last minute plane tickets. And then we do the survey. That's about 4 months out. And then they have 30 days to correct. That's kind of the typical process for this.
What's one thing that a lot of practice owners uncover and are surprised by when they do the certification?
Documentation.
Ah.
I talk a lot, as you can tell. I'm loquacious, but I want to make it very simple.
He's an attorney.
Yeah, documentation. No,
he wanted to be a litigator, but they stuck him in a room to do intelligence risk assessment.
I'm just an excitable guy.
He's fascinated about risk.
Yeah. We run the statistic for 15 years, 2009, so 17 years. We run it across all programs. If we run the top 10 deficiencies cited across all programs, 8 of them will invariably be documentation. Doctors, nurses, and providers are trained and passionate about assessing, diagnosing, and treating. They don't really love doing paperwork. And as an aviator, that's where the rubber meets the road, right? Yep. And so that documenting, logging, all that stuff is the big pain that everyone sees as being red tape and burden. But that's your visual cue that the consistency is happening. And that's what we see. Consents, histories and physicals, logs, especially when it comes to anything that's like autoclavable and sterilizable. Those logs and the control logs that you have to do to make sure that the thing is functioning properly and running, assessments. Those types of things are the things that across all programs, across all geographies, and across all provider types are 8 of the top 10 deficiencies every time. So I say that so that if anybody listening feels like it's their own struggle and they feel alone, you're not alone. Ask questions. Everyone's struggling with the same thing.
Now I want to take it back to the capitalist in everybody.
Yeah.
All right. So we're a sell-side M&A firm. We represent founders to get more value out of their practice. I believe Quad A and certification type stamps of approval are value add. I know from the buy side of private equity previous exposure that there's value in standardization, right? And so how do you see this playing out in terms of valuation for the individual and in valuation accretion of value for groups?
Yeah, so I guess this is where I give my other disclaimer, right? So 2 years, I took a hiatus from Quad A and I practiced law doing M&A for one of the largest law firms in America. So I advised on M&A, both buy and sell side. Lawyers, we don't really care. But I don't speak fluent M&A, but I do. I'm conversant in M&A. So I did that for about 2 years. And actually, the group that I work with focused almost entirely on mid-cap private equity and very large in tech, right? So I say that because I want to draw a quick comparison. When we were representing the buyer and there was a bit of code or a platform that we were buying, there was not a chance that we were going to advise on buying unless there was black duck assessments of the code and various assessments and credentials.
What is a black duck assessment?
So duck, and there's others, I'm sure, and I may
call it red cell, white cell.
Yeah.
In the Marines.
So black duck, I think, if I'm remembering, is an actual agency kind of thing. It's like a Quad A. They assess the code to make sure, one, no malicious software hidden in it, nothing embedded, no Trojan horse. They also make sure that the software, the code, they kind of do a comparison to make sure it wasn't pirated from anywhere, that anything that's open source is secured and safely locked down. So they're basically covering the risk of the seller, that the originator of this code is sort of opening up the buyer to all kinds of problems and risks.
It's a real Rolex. It's not bought in Phuket.
Yeah, right.
And then it stops working by the time you get back home to San Diego.
Correct. Or even worse, right? Like that the seller didn't have some sort of backdoor in, that they're just holding all your data, right? So that's a little bit of my background, and that's the way I see this, right? So we as Quad A have traditionally spoken to facilities, to societies, to congresses. And when I say congresses, I mean events like this, but also to legislators and governments and to academia. Where I think there's a completely different conversation to be had is in the investment world, in this world. with corporate practice and medicine rules, investment, I think, is a lot more fluid here. And so the idea here is risk, right? Right now, we don't know what's going on in the vast majority of clinics, in the vast majority of centers. There are so many novel therapies that are, even the FDA goes back and forth month to month on whether they're going to permit certain compounding, whether certain, I was just at IMCAS in Paris, and products that aren't even legally allowed in the United States,
Yes.
they're just handing me. I'm not even
Yes.
clinical. I walked back to my hotel room. I had 6 vials of stuff that I was like, I guess I could eject this
You
somewhere.
tried them all, and they're great.
Yeah. They were in the room. I was just
You
mixing them
woke
up.
up
Yeah.
and it was June.
Yeah, I was making a hurricane in
And
the,
here's
in the
June.
room. Yeah. And I was at an event earlier this year, and people were talking about energy devices that they'd purchased online. And they're saying, I can use this. And the experts were saying, but it's not FDA approved. And they're saying, well, but it could be okay if I do X and Y and Z. And the expert on the stage said, why are you trying to get me to say that you can do something that you're not legally allowed to do? You're never going to get me to buy in. Why do you want to do it? And if you want to do it, don't say anything to anybody. If you want to be the guy hiding something in the closet, why are you out here looking for legitimacy? The legitimacy is going to come when you do the things that are improved. So I think that's a weird dynamic that's happening here because it's so cutting edge, right? And you have traditional medicine looking at some things that we see here as snake oil, and you see other people saying there's tons of great science to back it up. And what we want is the right size of clinical rigor to allow an investor to appropriately gauge their risk. And when you look at it from a national perspective, because of what you said with the variations in law, because of what you said with the variations in practice, as an investor, whether you go from, from sell side, if I'm a single practitioner, right? I want to sell to a small cap, consolidator, whatever that looks like, or I want to become part of a big national franchise, national brand. Well, how do I let them know that I'm not all of a sudden a ticking time bomb for them? What's that outward demonstration of my commitment to safety and quality? And to me, that's what accreditation is. The manual has a couple hundred standards that nobody is clinically ready to go in and assess. So the certificate provides a single yes answer to all of those hundreds, right? So when I go from exiting as a physician or, selling off as a physician owner or a medical director owner to the consolidating group, well, this is my multiple to say I'm not a ticking time bomb. When I go from small to mid cap, same thing, and so on and so forth, because I, as the acquirer, know that owning one center is a risk of X, but owning 10 centers across 5 states is not 5X, and it's not 10X. It's probably 18 to 25X because of that variability. And my internal compliance person is trying their best to manage it without a system of management.
Aesthetics is a very sexy space. Private equity sounds very sexy, and people love the private equity space. And the reality is, private equity firms want boring, non-risky, reliable, right? And so that's why I believe that the bulge bracket investment bank influence on the large cap and the micro cap spectrum over the next several years is clearly going to be how do we differentiate quality from crap?
Yeah.
Right?
That's it, right? Like there's no indictment to say that this is needed in the market is no indictment of the market. It's not to say that anyone is bad. It's to say that the variability in the market is bad and the noise in the market is bad. It is detrimental to the market itself. So one of the really interesting things about antitrust law in Europe versus the US, talking about nerding out on you. One of the interesting things is in the US, when you're going to do antitrust, you have to prove damage to a competitor, right? That I've become so powerful, I'm damaging a competitor. The way the European Union courts look at it is that they anthropomorphize the market itself. And they say, have you damaged the market as though the market is an entity? And I think that's the way I look at it from this. The variability damages the market because it just creates this chaotic unknown and ambiguity.
One bad apple spoils the whole 100%. Bunch, right? And so that's what I think a lot of really high quality, exceptional owners and founders of these practices, they look at it as, is that we're doing things by and large the right way, the exceptional clinical way. And there's that one bad apple that spoils the bunch. And so for everybody out there, I think that's my biggest takeaway when I met Tom in Quad A was it's a way of differentiating yourself to say, we're not going to allow the bad actors to influence.
They can't drag me down.
Our industry. Yeah. Right?
They can't drag me down because I have this.
Yeah. And I think overall what that does is it creates a very a much more stable, a much more attractive industry for investment to pour into.
Yeah. I want to expand on one thing you just said. So you're talking about being boring and predictable and that being attractive to investment. And I'm sure you're familiar with Scott Galloway.
Yes.
And so Scott Galloway is really great about this. He says, I don't know anybody who's doing great at something cool. You don't want to be doing something cool. You want to be doing something boring. Somewhere out there, some guy is killing it because he makes that little metal ribbon that attaches a pencil eraser to a pencil, right? That's what investment is looking for in terms of stability, right? And so if you're an operator, or if you're a small cap, mid cap, or whatever, and you've got a system, got a platform in place, you look at standardization across, right? Your bookkeeping, you want it standardized. Your billing practices, you want it standardized. Your ordering, your purchasing, you want it standardized. You're doing all of that to make all of your various locations operate the same way because that's the way you can leverage the market. And that's the way you can increase your margins. It's the same with clinical practice, right? If your 15 locations operate the same way, and as a seller, that's how you should be thinking about it, right? I want to make myself as boringly attractive to that investor because all of my 10, 15 locations before I sell up to the bigger guy are operating the same way on the same platforms and the same systems with the same operating. And also, by the way, the same protocols, the same training methods, the same training cadence.
Yes.
All of that predictability is attractive, as you said.
Tom, one last question. What can we expect from Quad A forthcoming?
So sneak peek is, I think what you'll see is we are on version 1.1 of the standards because this is a very big, very diverse marketplace. I think people in the med spa space will see that standards are a living document. They evolve over time as the practice changes. I think we will get from version 1 to version 3 relatively quickly as we really get out there and see a lot of different facilities. At the moment, I think we piloted in 5 facilities. We've got 10 facilities fully in the program, and we've got input from whatever, say 45, 50 professionals. That's a drop in the bucket to the 13,000 med spas that exist. So we're learning a lot, as we all will, and the practices will change and the laws will change. I do think that you will see laws. I have personally seen draft of 2 laws in 2 of our more active states that would require accreditation for med spas. Thankfully, Quad A has 45 years of history with most of these states. So it's kind of ready-made turnkey legitimacy that they say, yeah, you accredit all of our surgery centers for us, or 75% of them. So go handle the med spas too. And then you'll see, I think, a plateauing and a stabilization. In terms of service lines, I think what you're also likely to see is wellness become more integrative into this process. As med spa evens out and maybe even shifts more heavily towards wellness and longevity than it does towards aesthetics, I think the standards will also continue. We sort of planted that seed, but I think it'll continue to evolve.
You talked about modularity.
Modularity, yeah. Modularity is my big nerd key term that I'm fixated on. And it's because all these multi-specialty facilities and systems are just that, multi-specialty. Right now we have 11 distinct programs: surgical, procedural, which is like scoping, GI scoping and things like that, med spa, dental. More and more facilities are adding to their cash mix by bringing those things together.
Yeah.
So our program over the next 2 to 3 years is going to evolve into a much more sort of bespoke custom menu where you kind of list out your services and the standards kind of accretes to you.
I think that's so important because it goes back to the space was defined as plastic surgery, and then it was defined as plastic surgery and aesthetics.
Yeah.
And then aesthetics is encompassing anti-aging, longevity, wellness, and it goes on and on and on. And so I think the a la carte menu that you described of the med spa that is in Des Moines, Iowa, that defines itself as aesthetic and wellness,
right,
is going to have a different menu of items that it's catering to than a practice in Boise, Idaho, that defines itself as aesthetic and wellness.
Sure, and even in today's state, in the current state, not even looking forward, most of the plastic surgery facilities we accredit have a med spa attached, right? Yeah. And so that's sort of going to be our first cadre of bundled facilities. As a plastic surgeon says, all right, well, I've been accredited for 25 years in my surgery center. That suite over there that's doing the med spa services hasn't been accredited, but now is the time for me to differentiate from the rest of the group because there's 25 locations in my city. That's how I do it, and that's how I step forward. And so I think that'll be sort of the initial group, the sort of standard bearers in terms of bundled services on our part. And we are trying, as you said, about differentiation, about educating patients. We're trying to add some value to that too by recognizing in every jurisdiction the first 10 facilities that get accredited in any one of our programs. So say med spa or dentistry or whatever it is. We do it state by state in the US. Outside the US, we do it by country. The very first clinic gets kind of you're the first. So that if 1,000 comes later, you never lose that. And the first 10 are recognized as pioneers.
That's smart.
Right? You're the ones who are leading the charge. You're the A students trying to be A pluses. When the C folks come along, they'll be able to show that they're accredited, but they'll never be able to show that they're a pioneer.
Tom, I can't thank you enough for joining the show today.
Thank you. I appreciate you tolerating my long-windedness and listening to the lawyer drone on.
Quad A, they're in the space. They're making med spas, longevity clinics, and just the overall industry better and safer for patient outcomes. And it's a much needed aspect of the industry that is going to benefit for years to come. So thank you so much. If you like that episode of Aesthetic Appeal Podcast, you can click on us and tune in for more at Aesthetic Brokers. I'm Bill Walker signing off for us today. Thank you.